Okay.
So the topic I was given is management of craniosynostosis. And now I have to see how I change my PowerPoint, because it's still on the first page. Okay, and I wanted to acknowledge something that, of course, I thank you for the invitation. I have no conflict of interest, but also that I was a little surprised by this title that I was given, because in Brazil, you already know how to manage craniosynostosis. I think the topic is very well known, and you all know already what a craniosynostosis is. So I changed a little bit the title in something more in, I think, a question, more than a question. What are the challenges we will face in the management of the craniosynostosis? So what we already know, but I wanted to focus also on what we still need to understand in the management of craniosynostosis. And of course, I wanted to also dedicate this lecture to Jim Goodrich, who was a friend of all of us and who participated a lot in the world of craniosynostosis, who had a very tight link with Brazilian colleagues. So I think it was normal, and I'm sure that also Michelle did it yesterday to show this picture, which was a great moment we shared with Jim. So first of all, this management of craniosynostosis is something that is different from treating a single craniosynostotic patient. It's something slightly different, because for the management of craniosynostosis, we need to understand the condition, and we need to tailor the surgery, the best treatment for the patient. And this is different than treating the craniosynostosis, which often is considered like performing an osteotomy, because this is what we learn, this is what we have told. And so we do these osteotomy lines. And this, of course, is something that a first-year resident can do an osteotomy. But this is not the management of craniosynostosis, at least as I understand it. And for me, it's something more large than just doing the osteotomy in the patient. The understanding and the management goes from understanding the condition, understanding what a craniosynostosis is, understanding what is the problem for the patient. Is it a functional problem? Are we talking about an aesthetic problem? And then once we have understood what the problem is, trying to solve it, and then finally treat the patient. So you all know that in synostosis, especially in complex synostosis or cloverleaf, we have a lot of problems. It's not only a synostosis. We have hydrocephalus, we have the problem of cognition, we have the functional problem in terms of vision, of breathing, of feeding. We have problem with chiari, with the syrinx, and other problems like the syndactyly, problem of growth, other organs that can be affected. And this is, of course, true in the example you see of a cloverleaf, in which we have scalpel problem, brain problem, fascial problem, skull base, spine extremities. But this is also the case in a single suture, like in this case, only one suture, but still hydrocephalus, still a chiari, or in this other case, very mild alteration of the skull, but still the chiari, still the syrinx. So this problem of growth of the skull and disproportion with the brain and also the medulla can occur in all the cases of the synostosis. We know already from more than 1 year that we can have extremity anomalies and head anomalies, since the description of Appert describing the feet and hands and the head. And we know now that the explanation comes from the embryology, from the common origin of the bones at the level of the skull base and of the long bones, and from the neural crest anomalies. So we have an explanation of this, but still it is difficult to assess which one is doing what. Our diagnosis will be of clinical. We recognize the face anomalies, we can recognize the anomalies of the hands, and sometimes other organs are affected, as I mentioned. And the modern tools can help us in defining these anomalies we have at the level of the skull, at the level of the face, and we can differ these different syndromes by these anomalies at the level of the cranial vault and on the face. But this improvement in the diagnostic techniques has a little importance in the clinical practice. Still, we have this clinical diagnosis of the facial extremities, and so we didn't go very far from what Cruzon has already described in terms of clinical diagnosis when you remain to the clinic. And we already know from the times of Cruzon, more than 100 years ago, that there is also a genetic background with a risk of hereditary cases that are from generation to another. And this is now better understood with the different syndromes that are described, with the different anomalies at the level of the genetic point of view, and also at the level of the different genes that can help us in differential diagnosis. So the main improvement in terms of diagnosis came from the genetic studies. And we know that now that there are several different genes that can be involved in the same pathway, explaining why the phenotype at the end can be similar. And you see here in the middle, for example, cetochoxin twist and TCF12 that are linked together, and then explain why there can be some similarities between these different syndromes. But again, we need to have this genetic analysis to better define them. So we had a shift from a pure clinical diagnostic tool to the genetic classification at the end of the 19th century, with the starting of the understanding of the genetic alteration that were underlying these diseases. And we know better the different growth factors that are involved only in FGFR receptors with the Pfeiffer, Cruzon, and Lappert. And now we can better understand why some of these cases behave differently. For example, the monosutural sporadic syndromic plagiocephaly is actually related to a mutation in FGFR3, which is one of the most common syndromes with the Muir-Key syndrome. And of course, this will allow us to better understand all the other problems that these children can have in terms, for example, of hearing. In this other case, it is a monosutural case. It's familiar. We see the face is affected, but only one suture is involved. So we see that there is a great heterogeneity in terms of gene, in terms of alteration of the skull. So we have same gene, several phenotypes, same phenotype, several genes, and there is no clear correlation, but still it is important to try to understand to better classify this patient. The example I already mentioned, twist and TCF12, like FGFR3, can give unicoronal or bicoronal synostosis. And why this is important for the clinician, it is because even if they are similar from the phenotypic point of view, from the clinic, from the radiology, they will differ in terms of risk of having a raised ICP. So the functional risk will be different and will be dictated by the underlying genetic condition. The knowledge of the natural history is also important, as you can see in these cases of acanthosis nigricans, with the change in the color of the skin due to the mutation of the associated to the syndrome. Again, another example of similar to Cruzon, it's another mutation with other problem at stake, so it's kidney especially. So it's important to recognize in order to have a better management of all the patients. Again, it's not only treating the bone of the skull, but it's treating the patient. Another example with this Carpenter syndrome, and the list of syndromes is very long, so we can have more and more examples. We have the metabolic forms, in which we have hypothyroidism, of course, but also other diseases of the phosphor or calcium metabolism with hypophosphatase, hypophosphatemia, giving different problems to the children and also the synostosis. The ciliopathy, why I stress that is just to remind that in ciliopathies you have also connective tissue, kidney, liver problems. So these children, even if you treat them perfectly well from the craniofacial point of view, they may still have a big problem from their heart, their kidney, sometimes they need a kidney transplantation, and the early recognition of the syndrome is of paramount importance to treat these patients. And one of the first doctors this patient might see is the neurosurgeon because of the anomalies of the skull, and it is important that at that point the underlying syndrome is recognized. Again, this is an example, the osteopetrosis, who will need a bone marrow transplantation. So it's important that we recognize the proper problem, not only the coronal occlusion, but the overall disease in order to treat the child. So the management synostosis goes beyond opening the coronal suture that is closed, because these children especially will need a bone marrow transplantation. And this is the same from the antenatal point of view, in which nowadays we have faced more and more cases, and we are asked what will be the prognosis, what will be the outcome, what will be the solution for our children. And this is important that we see the overall picture and not only the skull problem. Because we now have a very good correlation between antenatal and postnatal data, so we can give an idea to the parents of what they will be facing after the child is born. So we have this different type of problems: synostosis, hydrocephalus, vision, chiari, syrinx. Again, this is all the overall child that we need to take care of. From the neurosurgical point of view, the risk, of course, as you know, is that of having sequelae because of the hydrocephalus, because of the airway obstruction in complex cases, hindbrain herniation, venous hypertension, and the synostosis. And all this will give a raised ICP. We all know when we open the skull of this patient that these signs are evident at the level of the skull, with the digital impression, with the dura also, which is deformed by the pressure that is exerted. And we can see with perfusion studies, with ASL MRIs, that the perfusion of the brain is affected. And when we measure the ICP, we also see that ICP can be increases in all these cases, especially the complex cases. So we have a raised ICP. This is also due to the hydrocephalus, which will develop very rapidly in some cases postnatally, and especially in case of bilateral lambdoid stenosis. But we don't exactly know why these children have hydrocephalus, because if we take the example of the Mercedes type craniosynostosis, the sagittal and bilambdoid synostosis, the lambdoids by definition are closed, but still there is no hydrocephalus. Even if there is a chiari, even if the skull is small, even if there is a distortion of the aqueduct, like in a complex synostosis, the hydrocephalus will not develop. So all these parameters I mentioned, which we consider in the complex synostosis as a cause of hydrocephalus, actually are not sufficient. So the pathophysiology of hydrocephalus in complex synostosis is not clearly understood, and we have to try to classify. We consider that 1/3 is communicating, 2/3 is non-communicating, but still we don't actually know exactly what is going on. That is a problem. We assume things that actually are not true. The problem of not understanding why the hydrocephalus occurs gives us also difficulties in the management. We can wait and see, we can do an ETV, we can put a VP shunt. With the wait and see, of course, will worsen the functional prognosis, will worsen the cranial deformation because of the growth of the ventricles. But also, the other solution are not so easy. If we do an ETV, the anatomy can be distorted, can be difficult from the anatomical point of view, and also because of the age of these children. And we all know that ETV cannot be very efficient in some newborns, and this is the case in which in complex synostosis, the hydrocephalus will, the age in which hydrocephalus appears. And of course, there will be high risk of CSF leak because of the pressure. And then when you will do surgery on the vault, problem can also be worse. If we put a VP shunt, there is also the risk of over drainage. As you all know, the shunt reduces the growth, produces a secondary synostosis when there is an over drainage, and the risk is higher in a craniosynostotic patient, in which we will have a disproportion that will be increased by these over drainage, like in the example we see, in which there is a collapse of the ventricles, and this will also be detrimental for the patient. To try to reduce this risk of hyperdrainage, the idea is to try to maintain the volume, so we want a shunt that doesn't drain much. This is why flow regulated valve can be useful in this case, or at least all the shunts that reduce the risk of overdrainage. This is an example of a child with a Crouzon syndrome. You see the ventricles were already large very early, but they enlarge even more in the first months of life. You see the descent of the tonsils. You see that there is a obstructive also form of hydrocephalus, and then at the end the shunt was needed, and you see from the CT that the shunt already introduced a collapse of the size of the ventricles, but also of the growth of the skull. And you see at the, after the posterior decompression, the importance of having a shunt that doesn't drain too much in order to maintain the gain of volume allowed by the posterior wall decompression. And then there will be some kind of ossification. This is another example of a problem that we can induce in this patient, but overdrainage. You see the flatness which is induced by the shunt, and changing the type of shunt, it can allow to better remodel the posterior part of the skull and having a nicer volume. So we have the problem of hydrocephalus, we have the problem of airways obstruction, of course, more in complex synostosis, with the facial retrusion, with choanal stenosis, with the laryngomalacia also, which occurs that might need to be treated by a tracheostomy. So we have some cases with no severe obstruction, there is no respiratory distress, and then there is more of aesthetic problem of the facial stenosis. And in other cases, the problem of the facial stenosis is important from the ocular point of view, by the respiratory distress, and the airway liberation is mandatory. And this is why the airway obstruction needs a multidisciplinary evaluation. So the management of craniosynostosis goes beyond neurosurgery with the need of tracheostomy or very early facial advancement, which is difficult when the child has poor bone mineralization, of course. The facial advancement has the advantage of protecting the globe, reducing dysmorphy, and improving the breathing. And for all these reasons, it needs to be performed. But still, in the very first month of life, there is a limited place. Hindbrain herniation is another big issue in the management of synostosis. As you have seen, not only in complex, but also in single suture synostosis, it can occur because of the sleep apnea it can give, because of the synostosis that can occur. And there are several mechanisms that play a role in this hindbrain herniation. Of course, in synostosis, we have insufficient cranial fossa volume. There is an increased cerebellar volume probably in some diseases. We have an increased bone thickness. An example is in FGFR-related synostosis, the brain parenchyma is larger. We have abnormal bone thickness in osteopetrosis that I showed you before, fibrous dysplasia, and we can have an abnormal posterior fossa volume in other cases like in the complex synostosis or in the Mercedes type synostosis. And you see here that sagittal and bilambdoid synostosis are sufficient to give a hindbrain herniation, which is found in 2/3 of the Mercedes-Benz. So the closure of the posterior fossa seems to be important in terms of the volume and disproportion at that level. Then we have also the problem of the CSF dynamics. We know that hydrocephalus or the distal leak, anyhow, the gradient of pressure at the level of the foramen can play a role for the chiari. We know that hydrocephalus can induce a chiari, and we have also the example that the cure of hydrocephalus with the ATV can solve the problem of the chiari and their syngomelia. And we know also by the chiari 2 that the loss of the leakage of CSF and the gradient it gives will give rise to a chiari, and then that we can see antenatally. And then when we do the closure, there will be a reverse of this herniation. So we know that the chiari is not something that is static, it's something that is dynamic, and this is also probably something that plays a role in the synostosis. And then we have finally the abnormal skull base and the abnormal foramen magnum that also all play a role. And from the animal models, from the study of syndromic patient, we know that the skull base is also abnormal. We have a lot of animal models that allow us to study how things go at the level of posterior fossa, how we can get crowded, how the CSF spaces reduces, how the abnormalities of the bone develop and continue to alter the growth. And so we can understand that this posterior fossa also in humans is altered, and you see that the posterior fossa is abnormal in all these upper Crouzon, Muenke, and Pfeiffer. So even in the mild situation like Muenke syndrome, there is a big alteration of the cranial basis. The alteration is, again, a dynamic because of the fusion of the synchondrosis that occurs at different times. We earlier than normal, we'll have some modification, but will evolve with time, and especially in the very young. When we see the normal growth of the foramen magnum in controls, you see that it has a biphasic pattern with a very rapid growth in the first years of life and then quite a steady state. And you see that in Crouzon, the steady state is reached earlier, so there is less growth in terms of time and less growth in terms of volume. And this is found in most of the FHFR related condition, like in the Crouzon, Pfeiffer, Appert again, we have a reduced size of the foramen magnum, and also in Muenke, which milder form, but still a reduction in size. Of course, it is even worse in achondroplasia, as you can see in the far right. And when we see what are the clinical changes that can occur in this patient, the smaller the foramen is, the higher there is a risk of having hydrocephalus. So we see that everything is intricated, the foramen is smaller, there is an hydrocephalus, the hydrocephalus increases the gradient of pressure and probably increases also the evolution of the Chiari malformation, but this is not the only reason. Of course, if we take again the discussion about the achondroplasia, in the achondroplasia, the foramen is much smaller, as you can see again, than the other FHFR related condition, but still the hydrocephalus alone is very rare. We have a jugular stenosis, which is much more common. We have other problem of resorption CSF, but hydrocephalus is not so common as it should be if it were only a problem related to the size of the foramen magnum. And you see what we mentioned before, but still, the smaller the area, the higher risk of hydrocephalus, but still this does not explain everything because it's not true for a achondroplastic patient. Things can go very fast. We'll know also this. You see the evolutive, you see the very early age, 1 day of life, the position of the tonsils and the size of the foramen, and you see 1 month later, the hydrocephalus appearing, the Chiari worsening. So this is something, again, to stress that there is dynamic changes at the level of the craniovertebral junction in this patient during their early days. Giving at the end a competition for space, there is not enough room, and there is this tonsillary prolapse. At least this is something that this is how we understand it so far, with this proportion of the posterior fossa, this problem of the rapid evolution and differences due to the genetic background. But again, I stress that this is not the only problem. We need a combination of all these factors because individually, each factor alone probably is not sufficient to give all this problem. Again, if we take the example of the Mercedes-Benz synostosis, we have a problem of competition space, we have a problem of a small posterior fossa because of the lambdoid stenosis, we have the Chiari, but we will not have the hydrocephalus, but we have in a similar anatomical changes that we have in FHFR related condition. So the problem is the combination of all these factors, understanding which factor is more important. Foramen stenosis is not necessary to have the problem of the Chiari. Lambdoid stenosis is not necessary, but at the same time, we can have this problem even with patent lambdoid synostosis. In this example of X-linked hypophosphatemia, we have a sagittal synostosis in most 2/3 of the cases, Chiari malformation 20% of the cases, but still the lambdoid suture are normal in these cases, and as you can see in the image, the foramen magnum is large. And it is a competition of space, but not related to the growth of the lambdoids, not related to problem of hydrocephalus. It's probably due to the bone thickness, but again, these are only speculation. We still need to understand what is going on in these different patients to understand what is the pathophysiology of all these problems. So we have several hypotheses, we have several explanations. One we can exclude is the chronic distal CSF leakage, as in immunomeningocele, but or the tethered cords, but all the others still might play a role. The consequence of this in-brain herniation is, of course, the problem of the descent of this tonsil. There is a pressure gradient, there is a craniocerebellar disproportion, and foramen magnum anomalies. So we have these different mechanisms, different proportion, different timings, and it's important to understand that in order to tailor the treatment that this patient will need according to which is the most important mechanism and which is the timing during the life of this patient. Because we have different techniques, we can have a direct approach or indirect approach. The direct approach would be just open the occipital bone, the posterior arch of C1, and in craniosynostosis, duroplasty is not needed differently from a standard so-called Chiari type 1 malformation. This is an example. You see here the descent. You see that there is clearly syringomyelia. We can do a C1 decompression, the laminectomy, large opening, and the syrinx will stabilize and little by little solve. The problem of the direct approach in FGFR especially is that we can have abnormal venous drainage, and this there is this problem of the veins from the scalp, and even an interruption of those veins can lead to problems. This is something that is well known and regularly described in the literature with cases of problems with these enlarged emissary veins at the level of the scalp, with the severe morbidity and mortality at the time of incision. And you can see from this example that these veins can be very important. And when we measured, like Tatiana did, we had a big number of cases with abnormal venous drainage in Crouzon syndrome. You see that the collateral drainage is always present, with anterior marginal emissary mastoid veins that are present. And this is more common in cases with end-brain herniation, as you can see. Again, everything is linked together, and the more severe patients are, the more complex the situation is. And this is not the case in our type of synostosis, it's not the case in syndromic scaphocephaly, in non-syndromic scaphocephaly, or in upper syndrome. Again, the genetic background might explain some of the differences, but we still don't know why they occur. But we need to avoid them to reduce the morbidity of our surgical procedures. This is why we have also the indirect approach with posterior vault enlargement, which is a more recent technique that has been described, in which we enlarge the posterior part of the skull. You see here in this example of a Mercedes type craniosynostosis that it allows to reduce the disproportion, a better place for the cerebellum and the tonsils. This is another example. In a metabolic synostosis, with the descent, we do a large posterior flap, and then this will help in reducing the problem of the descent of the tonsils. In older children, we can use the distractor. Again, it will allow to reduce the gradient of pressure, reduce the problem of the disproportion, and have maybe an effect on the CSF drainage, but at the end, the result will be a reduction of the tonsil, a reverse of the herniation. And you see that it's very efficient in terms of clinical improvement. It's a little less in terms of radiological improvement, because in some cases there will be not this upward shift of the tonsils that we would like to have, but it can occur even if we do a supratorcular flap, which is limited to treat the gradient of pressure over the tent, not solving the problem directly on the posterior fossa. In some cases, we need a combined approach with a vault and posterior fossa decompression, like I did in this case, in which we had both a problem with fundus and the Chiari, and so we decided to go for a brain decompression and posterior fossa decompression with C1 laminectomy, which allowed to solve the fundus and the papilledema and reduce the size of the syrinx little by little, so with a good stabilization. In the combined approach, sometimes we also have the problem of VP shunts, and in this case it can be on the way, and there are risks of infection due to these distractors but go through the skin in these cases, and it might be necessary to try to reroute the shunt in order to have it far away from the skin incision and from the risk of infection due to the structure, like in this case, to avoid any kind of problem, infection problem on the valve. So the problem from the neurosurgical point of view are numerous, all of them going at the end to the problem of the raised ICP and the effect on the brain. But the brain itself can be also abnormal. We all know that in Upper syndrome, this is particularly true. We have a clear agenesis of the corpus callosum in some cases, so there is an evident abnormality that we can see on the MRI, CT, or ultrasounds in fetal ultrasounds. But this is probably also the case with more discrete and subtle alteration in Upper syndrome, but also in some of the single suture synostosis, which might be not so normal as the MRI can pretend. So we have skull vault, brain face, skull base, and spine extremities in the, and I'll show you in complex synostosis how all these are interrelated and how to try to solve. We have some surgical solution. We can remodel the anterior part of the skull directly with an advancement, or we can put a distraction of the skull and the vault and the face in some cases, or we can do the same posteriorly with a posterior osteotomy, which will, as I showed you before, increase the size of the skull, or doing a distraction posteriorly or posterior anterior, or we can add other type of hardware like springs posteriorly to increase the size of the skull to allow to have a better volume for the brain and cerebellum. All the goals of this surgery are the same. We want to limit the impairment due to the increased intracranial pressure, and we want to try to restore the form and the function with the least number of operations. So we have seen a trend in the years to shifting from linear craniotomies to very large craniectomies to a stage correction, especially in complex synostosis. We have seen that going to very early subtotal craniectomies or even total craniectomies would lead to poor results compared to having a stage release with different surgeries, repeated surgery. And more, the first line treatment will be an early posterior vault release in order to have a large expansion to solve the problem of the ICP. So nowadays, this is the first surgical procedure with these complex cases. Of course, there are some limitations because we cannot use many hardware in these patients because of the bone thickness and the skin erosion, the risk, and the patient laying on the back, that the effect of this vault decompression will be very limited. So there are a lot of limitations, but still more and more. The first step will be posterior, leaving the anterior part for later on, and then even later treating the face and the maxilla. What are the results of all these procedures? We still have heterogeneous results. We have morbidity and mortality, especially in the complex cases. We have higher rate for complex and for cloverleaf, for example, compared to single suture. And we have also poor neurological and aesthetic outcomes, especially in Upper syndrome. And when we see our results with these, even with these staged techniques, we see that there are still low IQ results, so low functional results in lots of uppers, as you can see, but also in some Cruzon and some Setter-Chotzen. So again, the understanding of the underlying condition is fundamental in terms of prognosis. We still, the cloverleaf is a good example with a very heterogeneous condition, very poor outcome, and again, the treatment should be tailored, taking into account the type of malformation that the child presents. There is high mortality in cloverleaf, we all know, because of the associated malformation, because of the surgical risk of hemorrhage, because of the respiratory distress. So the morbidity is high, already at the scalp incision, as we mentioned. But even in these cases, the idea is to have a stage opening with restoring the volume with anterior posterior increases repairing the deformity and trying to impair the CSF circulation. In complex synostosis, then, of course, as you know, there will be several other actors playing a role with the ENT, the maxillofacial surgeon, the ophthalmology surgeon. All these surgeons will intervene to treat the other problems that this patient will present during their childhood. So we need a multidisciplinary management, so it's not only neurosurgeon and it's also a stage. So there is a big collaboration that we need in all these different colleagues to treat this patient. In this single suture synostosis, the evolution was not exactly the same. It was not so linear as we have seen for the complex one, in which we moved to small to big and to then stage surgery. We are going back and forth from suturectomies and cranial wall remodeling. So there's a more circular story than a linear one. We had an improvement in the single synostosis, again, in the understanding of genetics. We moved to minimally invasive. We want to use distraction in some cases, want to use endoscopy, want to use spring, like people you can use in the scaphocephaly. But at the end, the goals of the surgery remain the same. We want to avoid the cerebral compression. We want to avoid the dysmorphy. We want to counteract the progression, the evolution. But we also want to achieve the better neuropsychological outcome. And this is something that sometimes neurosurgeons tend to forget, because we sometimes think that the osteotomy is the solution. But is it really the case? When we see the results of what we're doing, this is the series from Régnier and the 40 ans malades of 15 years ago, we see that despite all these good techniques, the results can still be poor. And we know, all of us, having done some cases, but we have all of us some poor results with scaphocephaly or for plagiocephaly, just to give two examples of unisutural synostosis, both from an aesthetical point of view and from the functional point of view. So are we talking about different patients? Why do we have these poor results? Is this because of the background? Of course, we know that some just one suture can hide a complex, like this case, like in this example. This is a scaphocephalic patient, but actually it's a Cruzon with FGFR2, and the time will explain the failure of a procedure for a scaphocephaly. Or sometimes we can have poor results because there is a chromosome abnormalities and the brain is underdeveloped. And the list of genes that are involved is getting longer and longer. So some of the explanation can effectively be because these genes are interacting the growth of the skull are altered, and they alter also the brain, the results will be poor or the recurrence will be high. So yes, there are different patients, but there is also the discussion of are we analyzing these patients. So if we take, for example, scaphocephaly, we see that there are different shapes in the scaphocephalic patient, different angles, different sizes, as you can see in this example. All different CSF spaces, different size of the ventricles. So all these differences probably are to be understood and can explain partially, at least, our differences in terms of results. So we're probably mixing all the patients together. We consider that scaphocephaly is a single entity, but which is not. The same for plagiocephaly. Probably there are different subtypes of scaphocephaly, plagiocephalys, trigonocephalys that explain why we, in some cases, we have different results from the functional point of view and aesthetic point of view. But also the choice of the technique. We tend to use always the same technique for the same type of synostosis, but probably this is not also the good solution. And when we compare the different techniques, and we take studies that compare the different techniques, you see that we have an effect of age, which gives us the information that we can modify the neuropsychological outcomes just by choosing the right timing for surgery. But when we see the type of surgery, we see also that there are different outcomes in terms of IQ, for example, when we compare different techniques. The type of surgery seems to have also an impact. As far as this study is concerned, the cranial wall remodeling had a better result than endoscopy. And this is another study which goes in the same direction. This is a group from Rotterdam. They study a patient with scaphocephaly. They operated with extended strip craniectomies, and finally they found that 10% developed papilledema in the postoperative period. And 10% is not so far from the 15% of raised ICP that Renier measured before surgery. So the question is, are we really changing the natural history of the disease with this technique? And when they try to study the patient using springs, they saw that the postoperative papilledema rates had decreases in their spring series. So the question is our spring better than the extended strip craniectomy we were using? But we can also ask, is extended strip craniectomy changing something from the natural history of the scaphocephaly from the ICP point of view? But nevertheless, we can conclude that type of surgery has an impact on the outcome. So it's very important that we understand which surgery the patient deserves, because probably we are comparing different techniques and different patients. And all of this makes our mixing apples and oranges and the conclusion are difficult to be definitive. There is not only one scaphocephaly, there is not only one plagio, there is not only one trigonal. We're talking about different types of synostosis and again, different patients. And we still, and this is the big challenge for us, and no clue on the indication on these synostosis. And we have no clue on the functional results because with not knowing how we have to analyze, we cannot have the good indication for surgery. So this is another example to see how things are complex. Even if we think they're easy. Trigonocephaly, 8% of them will develop raised ICP, so the rate is very low, but still we do surgery in our patient. And this is a child who came to my clinic with trigonocephaly. There is a light hypotelorism, there is a crest that of course on the picture is always a little difficult to assess. And discussed the parents with the risk of ICP and all the things that we usually discuss. And then the parents said, oh, but I had the same thing when I was young. And I said, well, maybe you had a crest. I don't think you really had a metopic synostosis. I said, yes, I was the same, it was even worse. Are you sure? Because you don't seem, your forehead looks normal. And then he brought me the picture when he was born. So this is the father at the time he was baptized. And you can see that he had a nice metopic synostosis as his daughter has now, even worse, but still nothing, and it was of course not operated on. So probably we don't know exactly what the natural history of all of these conditions are. And we know that there'll be an increase in the incidence of metopic synostosis, but this incidence was, when we see the numbers, started 30 years ago. So now we should have had adults with trigonocephaly, unoperated trigonocephaly around. If this increase was so important in all the part of the world, we should have seen patients with strange foreheads, which is not the case. So either we operate them all, either there is a normal evolution and normalization of the forehead in trigonocephaly, and this should question us on what indication in this case is. So to understand the indication, we need to have an idea of the outcome and compare the outcome with the natural history and the outcome of the surgical series. But we don't have very good outcome criteria. This is the problem we need to solve. When we consider how we can evaluate our patient, we have, of course, functional elements, ICP, fundus, IQ, other neuropsychological tests, or functional imaging to see if there is a distortion of the brain. But what we use in most of the papers are just aesthetical criteria. How is the scar? How is the cranial index? How the patient is judged by the surgeon or by his parents? Or we have a surgical criteria. How long was the surgery? Was the patient transfused? There was morbidity and mortality? Or even, for me, worst criteria, like the length of hospital stay, how many days it remained in the hospital, how much it cost. So most of the papers nowadays only stress on these aesthetical or strictly surgical or administrative aspects of the outcome. And if we can use this, the best technique for craniosynostosis will be helmets without any surgery. If we put an helmet, and this has been tried in non-operated scaffold, we can improve the cranial index, we can improve the size and the shape of the head. And of course, there will be no scar, no surgery, no transfusion, no morbidity, no mortality, no stay in the hospital. So from this point of view, the best solution will be the helmet. But of course, in a synostosis, putting an helmet, it will be even worse from a functional point of view. So it's essential as neurosurgeon that we remember that we need to protect the brain, and we need to have outcome criteria focusing on the brain, not on the aesthetical part. So we need to develop good surgical evaluation tools in the next future in order to improve our management of the synostosis. Because if we want to resume the history of the craniofacial surgery, we start in the 19th with Lyon, with Virchow, describing the different shapes and the different anomalies. And then the surgery and the anesthesiological techniques improved. And this allowed pioneers like Tessier and Guillot to develop complex surgery. And because they were able to do things, they developed the indication. So the indication followed the solution, which was the technique that was developed before even the problem was actually understood. Now we focus on the mortality and the morbidity. We know better how to reduce the morbidity of our procedures. But at the same time, we had also improving the genetics in general in the understanding of the underlying condition. But where are we going for the 21st century? And I think what is essential is that we start to evaluate what we are doing, to start to see why we are doing this. Not only how we do it, my technique is better than yours, of course, but why I use my technique and why I do that and why I expect those results. So the indications must be discussed. So our challenge is improvement in the understanding of the pathophysiology, improvement in the understanding of our results, to compare the different results, compare the different patients, and to tailor the indication and to tailor the technique to the single patient, not only to a single type of synostosis. So we have to refrain for operating them all. There are probably 1,000 of patients that have been operated unnecessarily, but we have to understand which one really need to be operated on. And then we have to refrain to use the same technique for all the same synostosis. Probably we need to have a large spectrum of techniques to adapt to every type of scaphocephaly, every type of trigonocephaly, every type of plagiocephaly, in order to have the better treatment and the better outcome in the single patient. Of course, as you understood, it's a lifelong commitment. We need to follow this patient at least for 10, 15, or 20 years to understand what our results will be. We need a big, large multidisciplinary team in order to treat this patient, to manage this patient correctly. But the neurosurgeon must remain the leader of this team. It's a neurosurgical issue, it's a neurosurgical problem, and we should not forget that there is the brain we want to protect, and the brain should be our goal. Protect the brain should be our goal. So I thank you for the attention, and I'm ready to answer the question if there are any. Thank you.
Thank you, Federico. Nice presentation. Very nice presentation. Barbara, are you here? Okay. Nilsi, if you can, would like to say something just to start in the discussion.
Yes, fantastic. Like usually, Federico, excellent conference. We learn a lot every time. You talk about it's different to measure, to have the good answer. If we are doing now, how we can measure that it's the best, is the good for the patient? We don't have the right tool to measure. My question is for the late diagnosis and the late indication for surgery. You show that in the scaphocephalic patients, yes, we can lose intelligence if we do later on. But when you have the scapulocephalic patient with 3 years old, never operated before, normal life. Did you indicate surgery only for aesthetical reasons, or you may discuss the subject with the craniofacial, the family, and try to have the right answer for each patient? Or you have more or less a statement, if after 2 or 3 years, I don't operate anymore?
Well, thank you, Nancy, for the question. I think, again, that the answer is not only based on age. The question is why the patient is at your clinic age 4. And there are lots of different scenarios. The patient can arrive at age 4 because he has a mental retardation or the behavioral problems. They did an imaging and they found Chiari, acidostosis, and something else, but the patient is symptomatic. Then there is a situation in which the patient, the deformation was recognized when the child was born, but nobody cared, or he was not able to be taken care of, like he had a heart problem, nobody considered surgery, he had several issues, but the problem was there from the beginning. And then there are other mild cases that are recognized just because the child does an examination for other reason with no real functional issue, like he does a trauma, it has a CT scan and they see that the suture disappeared. Other example, he comes to you at age 4 because he has a metabolic disease which has been recognized, and in the screening of the metabolic disease, the doctor does a X-rays and they see that there is a suture loss. So you see that your simple question is, do I do surgery at age 4? Can be declined in different groups. So if it, I would start to say, if it's asymptomatic, of course you can leave it like it is. If it's symptomatic, you will go for surgery. But then you need to see what is symptomatic for craniosynostosis. This is, again, the question, what is the natural history? Is it having problems because he has the genetic problem, or because of the synostosis? The idea is that if there is symptoms like fundus papilledema, if there is a complaint, he has headaches, any age, can be 8, 10, I will go for surgery. And when I say 8, 10, it occurs to me in the metabolic group to have patient with just sagittal suture loss, developing papilledema and headaches when they were 10 years of age. So it can occur very late. And it will solve with the cranial decompression. And this is not an aesthetical issue. It's purely a functional issue. And then there is a very young, age 2, the mother comes to say, oh, he's really deformed. I told the doctor, but he said, oh, it will go away. Now he's age 2, he has a front very prominent, he's very narrow. For me, it's very disturbing. And in this case, of course, the discussion will be more aesthetical and discussed with the family, the pro and cons of doing an aesthetical surgery in a child who is quite old with less good results than if we do the same when he's very young. But in that case, the surgery will be aesthetical and the technique will be different. Because of course, because your goal is to improve the shape, you will need to manage the forehead, you will need to enlarge more importantly than you would do only for a decompression for raised ICP.
Thank you.
Okay, Federico, I'd like just to make a question to you. When you say when you said about very early facial advancement, what exactly you said? When how age is, in your opinion, the minimum age to propose a facial advancement?
So the facial advancement, you have to really to think on what is the benefit for the child. In the very young, if the malar bone is big enough, you try to put a transfacial pin, which goes from one side to another, and you pull. This is, of course, there is a risk of infection, there is a scar, there is a problem with the teeth. So and the child needs to be pulled for a long time under sedation. So there is all this risk and cost for the patient and families and society. So this has to be weighted to the what the child really needs, tracheostomy or a mask. So the indications are very limited.
Okay, but for instance, for the for the clover left case, do you prefer tracheostomy, of course, instead of transfacial pin?
Yes, the transfacial pin will only solve the problem at that level. This patient, as I mentioned, they have also some tongue problem and some laryngomalacia. So if in our case, the ENT does the evaluation. If he says there is even a mild sign of laryngomalacia, we don't go for pulling because it will not solve the problem and it will only give a risk for the child, and at the end, it will need the tracheostomy anyhow.
Okay.
Okay.
Yes, Benicio?
Benicio, would you say something?
Yes. Hi, Federico. I think you still have the Darth Vader sticker on your notebook, don't you?
Yes.
All right. But we're not on the dark side of the force, I hope. Well, Federico, we are addressing the abnormal venous drainage. And how do you deal with the problem? Sometimes you have a real sinus pericranium sometimes. You do contrast exam in, most of the patients have complex synostosis or not. And when you happen to find one, how do you deal with that?
So yes, the routine is to do at least a TOF MRI. So MRI with TOF sequences, time of flight, and we can reconstruct the veins, or better, the injected CT scan. Then it depends on what you need to do, because if you really need to do a posterior surgery or a surgery that involves this vein, you can do a stage surgery. So you just cut some veins and wait, cut some veins and wait. The worst is to cut all the veins at the same time. But in most of the cases, at the end, there is also the possibility to try to avoid it. For example, if we do a distraction, we don't go so low as we do for the posterior fossa decompression of typical C0, C1 surgery. So the idea is also to find the right timing, because these veins will also evolve during time. So maybe you can postpone the surgery, discussing with the parents of the risks.
Sometimes you had to give up the surgery because of these veins?
Yes. Yes.
Federico, Hamilton.
Yes.
Please.
Federico, thank you for your really good talk. I agree with you that there are many different patients, different syndromes, and it's very difficult to have one kind of cake recipe to everyone. But I want to ask you about those cases that you mentioned that develop headache or increase ICP following Hydrocephalus surgery. Is this situation correlated with the secondary coronal suture synostosis?
It's probably more common in this patient who have a reduction in the growth of the head circumference and the secondary synostosis. The secondary synostosis can occur depending on the different techniques and can occur on the coronal, but also lambdoid in some cases. And it's still unclear to me if it occurs more commonly in those in which there is a big change at the beginning of the growth and the head circumference compared to those in which the changes are less important. Like if we enlarge very rapidly, then it will fuse more rapidly, and then we'll be unable to change. So I don't know if you see my hands. I think I have to go like this. So you have a very rapid, and then it goes straight. straight for the head circumference. These are more at risk than those who go little by little, continue to grow like normal.
At what age did this patient become symptomatic?
From 6 to 10.
6 to 10. It's a little bit later because the head grows very fast during the first year, then decrease in the second, but 3-4 years they almost stabilize in
Yes,
growth.
it continues to grow. It continues to grow until 18. So, but the problem is the change in the type of growth, because in the first year of life, the growth will be, because of the patency of the suture, will be by the center of the ossification. So the head grows and the ossification goes from the different ossification centers externally, and it will continue. After age 2 or 3, just the growth will be only by remodeling from the inner surface,
inside to outside,
inside from outside. So there is a change in the type of growth, and this will modify the things, because in the first years you do the surgery, it's open, they can continue. Then the fact that the size in which they reach is not sufficient will decompensate later. But this is probably why some of these patients develop this problem, but it's not only the technique, probably there is also a background which makes this ossification different. So I don't know if the loss of the coronal is a marker more than the cause.
So you mean that the problem is not related to the technique that you are using? Probably.
This is not exactly what I'm saying. The existence of the suture is probably related. And paradoxically, the suture tends more to disappear in the techniques in which you respect the suture during surgery.
Okay.
So if you leave the suture, but you do your cuts really close to the suture, you alter the growth, and statistically, the suture might disappear. If you remove the suture during surgery, there is a regrow, and the suture remains the center in which this regrow will be, and you will find a suture-like signal on CT scan more frequently. But this is just radiology. I have no clue if the suture is working better or not. But it's very simple. Your site of fusion remains at the level of the suture. So you cut the suture, and you recreate the natural things. There is no bone, and the bone from the parietal size and the frontal size will go towards the coronal region, and they will create the suture.
Okay, thank you.
Salomon, would you say something? Busy, please.
Busy.
Hi, Federico. Thank you for a nice presentation. Good to see you. I have a question regarding metopic synostosis. It's always difficult, a question of indication, considering the severity. So it depends on how you see. So you go from a really very severe trigonal synostosis to only a metopic ridge. So you have this spectrum. My question is, do you use any particular number, like the interfrontal angle or any other measurement, to say, well, this is severe enough? You know, these people in Duke University, they did this measurement of the interfrontal angle, and they established 118. So less than 118 is severe enough. Above that is not severe enough. I don't know if you see this paper.
Yeah, I know. So this really depends. It depends on the
What do you think?
family. There are families who need numbers, so I give 134. Because when I compare when we measured in our department things, we saw that we had different type of other problems associated depending on this 134. But this is something that is just numbers, and depending on the angle of your CT, your angle of also will change. So there is no real value on the angle. The modification we have in the Hydrocephalus are very interesting, because this is again the problem of the timing. My feeling now is, as I've seen 1, 2, 3 cases of disappearing trigonocephaly, is that the trigonocephaly disappears. The problem is that it takes time, it takes years to disappear, and during this time, the brain is probably compressed. So the question is this compression important enough to do the surgery in order to avoid it? Or is it very mild? And in that case, what's the point? That's why I started to see if perfusion could give an answer. If the CSF spaces are different, if there is a compression of the sinus and so on. Probably the bigger problem we have, at least as far as one of my hypotheses is that the bigger problem we have in the midline synostosis compared to the others is that we have a constriction on the sagittal sinus. And the constriction on the sagittal sinus gives raised venous pressure, which alters the dynamics on the brain. So the problem gets more important than only the stenosis by itself. Is the compression of the sinus. We have abnormal veins. We all know that when we do the surgery on scapholes on intrigonals, we have abnormal veins, emissary veins, what we don't find when we open for a tumor or we open for another type of disease. So there is an alteration of the sinus, and this alteration gives a chronic raised venous pressure problem, which we'll solve during time. But probably this is why it's important to free the sagittal sinus, and this is why all the techniques in which they take care only of the shape and not on the functional aspect will not give good results. And the problem is that in our reflection is that we are flowed. We have the problem of the studies that have been done using the P technique as reference. And when you see the P technique, you do a cut parallel to the sinus, you remove a small piece of bone on the sinus, and you pull to decrease the size. So what you are creating is keeping the constriction on the sagittal sinus, and you're pulling even worse on the sagittal sinus itself, on the frontal part, because you want to force the enlargement. So this, from a functional point of view, is a nonsense. It's purely aesthetic, but it's used has been used as the gold standard to say, look at the functional results after the surgery. The IQ of patients that have been operated on with the P technique are not better than those who people are not operated on. But this is probably a problem of the technique. So this is, and it's the same question in the trigonocephaly. When we measure the smaller the angle was, the more signs we had of constriction on the sinus and more abnormal veins we could measure, and the more CSF spaces were altered. So probably everything is linked. So there is an issue with the size of the angle, but what is the normal threshold? What is the best threshold? I don't know, because to give a good threshold, you should have a good evaluation of the outcome. I do surgery for 120, I have result A. I do a surgery for 116, I have result B, but we don't have it. So I cannot give you a good number. So my guess is 134, but you can give your number and it will be the same. So just pick one number.
Yeah, one more question. Sometimes do you believe in trigonocephaly, you always have a compression of the brain, or sometimes you don't? I feel that instead of compression, you have a frontal atrophy.
Yeah, but this is another problem.
Development of the frontal lobe, and that's why you have the trigonocephaly.
If there is a brain atrophy, you have a microcephaly, the frontal bone will not develop, the suture will fuse, and you will have a mild trigonocephaly. So this is a different problem, is the absence of growth. So it's fundamental to distinguish these cases, because doing the surgery will be purely aesthetical with no functional results.
Yeah, but
So-
I'm telling you, not in the microcephaly. Sometimes you see all the other lobes well developed, but the frontal lobe. So you see the trigonocephaly and a lot of space and CSF space in the frontal lobe. Looks like you have a localized frontal lobe atrophy, and that's the cause of the metopic synostosis.
I'm not so sure. You can read it the other way around. You can read it like there is a compression of the sinus, a bad resorption of CSF, and then accumulation of CSF. Scaphocephaly is the same. 50% of them will have larger spaces, 50 small spaces. Plagiocephaly is the same. You can have increased spaces at the level of the compression. So it's not so clear if the compression is a bad sign or a protective sign, kind of keeping the pulsatility to try to fight against the compression.
All right.
Okay, Federico, we have some questions from the audience. The one question is, do you think that, from Mario Salmon, do you think that every patient with a cranial vault anomaly should have genetic counseling, in your opinion?
Well, it depends on the local resource and what is the aim. If I want to be provocative, it's the same idea of doing a brainstem biopsy in the IPGs. So the idea is, if we want to know what we're doing, if we want to classify correctly the patient, if we want to improve our knowledge and give a good prognosis to the children, yes. But if you cannot afford it, I can understand that you don't do it. The advantage of that is that you are able to clearly classify. So for you, you have a good classification of your cases. For the children, you can give them the risk of recurrence. The risk will be different according to the syndrome and the genetic things. And you can foresee problems for the family and the risk of recurrence for the family. So for all these reasons, it says yes. Then, of course, you can also wait to see how the child goes. If the child develops perfectly, you can avoid it. And if the child at age 4 or 5 have school problems, or age 6, you can do the testing at that age. And then you will tell the family, he has a problem at school because he has a chromosome 9 anomaly. But it will be, at least in France, in which the test is available, it's more difficult to explain to the family 5-6 years later that the problem are not related to the surgery that they have done, but to other issues. So in our case, we try to do them in all cases.
Okay.
There is, yes.
Yes, we have another question, and then
Yes,
you'll see, please follow.
The,
If you, when you need to indicate a shunt to treat hydrocephalus, which kind of valve do you use? Do you use, the question is from Maximo Teles, if you use programmable valve in those patients or not?
well, you need to use a valve that drains the minimum possible. So it's either a flow regulated or programmable valve or anti-siphon valve. All these valves that allows you to have the least slit and the least over drainage. So what you don't want is to drain the CSF and having a problem with the growth from the inside.
In
Okay.
the same,
Please,
Ricardo, there is a question in the same sense from the chat. It's from Silvia Quintero. She's asking if you correct craniosynostosis secondary to over drainage of the shunt, and if you do, what kind of surgery did you promote? I see only once. It was in a paper about good results, but a very small series with springs of Lauritsen to correct deformity after VP shunt in the newborn. Did you correct this kind of synostosis secondary?
Yes, we do. And the Okay, let's say Lauritsen uses springs for everything, so it's not surprising
Okay.
that they use the springs for correcting the secondary synostosis, as they have a very good experience with all type of synostosis corrected by springs. Having said that, I would be afraid of putting material in some patient who already has a shunt, and if there is any infection with the due to spring or breakage of skin breakage, you will get even meningitis and other problems. Having said that, yes, it happens to us to do this type of surgery. Of course, first of all, you have to try to treat by the shunt. I mean, it's a problem of slit ventricle. It's not only a problem of craniosynostosis. It's the management of slit ventricle syndrome with all the management of due to the valve. If everything fails, at that point, if you have some concordant signs of failure and disproportion of the skull, you do a vault remodeling, but it's a little different from a standard synostosis, because there should not be any aesthetical issue. It's purely a volumetric issue, and is the problem that the skull thickness is increased, because this patient with chronic hyperdrainage, they have a very thick skull compared to normal. So it's different from the synostosis. And the management will be a reduction of the thickness of the skull. So the easiest management to do is to do a parietal or frontal, whatever you want, flap, and reduce the thickness and put it back. So there is no modification in the aspect, and there is an increase in volume. Because again, these type of problems, they occur later on in life. So when we are only facing a type of growth with remodeling, not with volumetric expansion, but just a change in thickness.
Did you indicate once only for aesthetical reason for deformity? A VP shunt, the shunt is working, only deformity later on in life. Some families asked for aesthetical correction. Did you see a good reason to do?
So I've seen patients operated for aesthetical reason after shunt. So I've seen, yes. Is it a good indication? Aesthetical, it's difficult to syndicate. Is a good reason to change the nose? If it's important for the patient, is it important for the family? Why not? But they need to understand the risk. I mean, the risk of touching the skull and touch is still for aesthetical reason. It's something you have to discuss.
Thank you. Ricardo?
Tatiana, would you say something?
Yes, Fede, thank you for your presentation. A lot of experience to share with us. Well, I have a lot of questions. One simple question, how do you use cranial index? How is it important for you, no matter if it's non-syndromic or syndromic craniosynostosis? And also, how do you feel about the use of tranexamic acid, erythropoietin, and iron supplementation before surgery?
So for the cranial index, I rarely use it, only for papers. So when you need to describe the series, I take the CT scan I have to measure it. So in real life, I prefer to use the head circumference to know how the child is growing. And I don't use the cranial index every day. But some of my friends do, so why not? But not having a cranial index has not given me problem in my experience. But I'm lazy, so I'm not to be followed for this. For the rest, again, because I'm lazy, I'm happy my anesthesiologist use tranexamic acid, erythropoietin, and all the things that you can do to increase the hemoglobin. And we have seen when we measure it here in Lyon that we change the transfusion rate in our experience, because the transfusion rate is might be an issue for some patients. You can reduce the risk, or at least reduce the amount of blood they need to be transfused with all these techniques. And we had something around 100% of transfusion, for example, in Hydrocephalus, before the use of tranexamic acid and erythropoietin and so on, it went down to 80%. But it's still high. So it works, but it's not enough. But probably it reduces what our anesthesiologist says, it reduces the amount of blood the patient needs, which means a reduction of the risk with the transfusion from different donors.
Ricardo?
Please. Henrico, please.
Hi, Ricardo. Hi, Federico. Thank you for excellent presentation. I would like to come back for about the emissary veins. Do you think that as the time goes, if the patient become more and more dependent of these emissary veins, and if they are young, they are not so dependent of these, and about the use of digital angiography for some challenging cases, like Busy asked it, I don't know if it was Busy, but about when you have to do a posterior vault distraction, sometimes you have some emissary veins down there, and you said that sometimes it precludes for you to go back there. And if you use some digital angiography, it can show you about the dynamic of this venous flow, and to say if the patient is dependent on these emissary veins or not. What do you think about it?
Well, I don't know. I don't use the digital angiography, so I cannot tell you if its use will be interesting for me to see.
Yeah.
I just have the CT, injected CT and angio CT, or the angio MRI and the TOF MRI, as I mentioned. So I cannot answer properly to your question. I'm sorry, but from the general point of view, yes, the veins can preclude the surgery. They can be very disruptive in terms of blood losses, and even put at risk or kill the patient if they're in some cases. So it's better to sometimes to stop or to avoid the surgery than putting at risk the life of the child if these veins are draining all his brain. And they can change during time. This is something also that can occur. So there are some modifications. So even if you did, it's better to redo before going to surgery to see if there is a modification or not of these veins.
Okay.
But then I have no experience with the angiography by itself. If people try to stand, to open, to do things. So this I cannot tell.
Okay, thank you. And I saw in your presentation that you, at least at your case that you showed, you use the shunt on the posterior here, in a posterior shunt, not in a frontal shunt. Do you think that frontal shunt could be better to a better first step, so you don't have no problem to do the posterior distraction after? But
then you will have problem with the anterior part. So the shunt will be in the middle anyway. So because if you want to do it, if you put in the front and you do the distraction, you will still have the drain in the middle of your way, because it will go somewhere in the back. And when you will do your frontal distraction, you will have the problem of dealing with the shunt on the front. So technically, the idea is that if you put the shunt peritoccipitally, your catheter goes straight to the ventricle. Okay. And in the worst case scenario, if it's long enough and you pull it, it will remain the ventricle. Okay. If you put it in the front and then you move transversally, you don't know where it's going. So the idea is to put it there. If it's distracted, but you put 5 centimeters and you still have 4 inside, it will be safe enough.
Okay, thank you.
Dr. Salomão?
Yes. Federico, congratulations.
Thank you.
Thank you for your wonderful presentation. I have a question regarding distractions and also springs on the vault. I would like to know if you particularly think that there is a strict indication for these procedures. or when do you indicate distractions or springs?
So it depends in which direction you want to enlarge. For the anteroposterior distraction, it clearly works. So it gives very good results and is very useful to solve all the problem of cranial compression and craniocerebral disproportion. So it can allow you to enlarge nicely the vault with very good and fast results. So springs are a little more complicated to use if you use with a patent suture, or if you have to do the osteotomy, it's a little more complicated, and you don't actually know exactly how, I mean, the position of your vectors will change depending on where you put your springs, how many you put. So unless you are Gilani, who has done puts thousands of springs that he owns in the patient, and you know exactly how many newtons because you talk with your engineers and so on, you have a good condition, knowledge of what you're doing. It's difficult to use. The advantage of the spring, that there is nothing outside, so there is no problem of less risk of infection, but the disadvantage for me is that you control nothing. With the springs, you're able to control how much you want to distract, and you can go both ways. So I've seen just an example for a optic nerve that was pulled too much, and if you go back with the problem solves. So there is this, the other advantage is that with the distractor, the child can lay on the back of the head because the distractor is a retainer. So when you do a flap, posterior flap, if it's a free flap, the child is forbid to put on the back because it will collapse the flap. But also with springs, there is this movement, which, as you know, will not allow you a very good ossification, because if the bone moves, it doesn't ossify very well. With distractors, at a certain point, you will avoid this, and you will have these retentions. So every time the child can have a better life for me with a distractor, even if he has the distractor that goes out from the skin. In the transverse way, springs and distractor have been used in scapulocephaly to enlarge. So I'm not so sure that distractors have a role in this situation, because it's rare that we need to have 3 centimeters of lateral enlargement in these patients. So do we really need distractors? I don't know. And then it's a second surgery to remove them. And this surgery is all around the sinus. So every time there is a little risk of doing a bad maneuver and pulling something that you don't want to pull. Same thing for the springs. That's why now the springs are put on the side of the sinus, not anymore on the sinus, because they are too dangerous on the sinus. There have been catastrophes with springs put medially. But at the end, my question remains to all these patients, all these surgeons, and what happened to this patient in which the springs is placed parasagittally, and the sinus and the midline remains covered. So we are going back, as I mentioned, to the P technique, in which you don't touch the midline ridge, you don't touch the problem, you only want to enlarge, but you don't solve the dynamics related to the sinus we mentioned before. So I don't know what will be the functional result of this. Clearly, from an aesthetical point of view, they work, but in the very young, from the functional point of view, on the solving the problem of the dynamics, I don't know if they work. So my feeling, again, is that patients are not all the same. The functional problems on the sinus, probably they don't exist in all the cases, because we have different shapes of the closure. We have the flat closure, we have the one who is like this, and we have the omega one, in which there is a big ridge. And these are the patients which sometimes you actually, when you do the surgery, the sinus goes outside and comes back. I think you all have seen this big lacunae purely on the midline. So in this patient, the dynamics of the flow is different from those who have just a flat contact and fusion, which is more close to normal.
Okay.
Thank you very much.
Griselda from Mexico, do you have any comments?
Congratulations, Federico. What do you think about the use of flow regulation shunts for prevent overdrainage in hydrocephalus and craniosynostosis?
Yes, flow regulator are a good solution to avoid the overdrainage because they reduce the risk of overdrainage in general. They are especially interesting in these kind of problems because they should reducing the overdrainage, they reduce the secondary problems.
Okay. When do you use monoblock technique in syndromic craniosynostosis?
Well, the monoblock you ask.
Yeah, monoblock technique.
Well, the monoblock, I mean, Mexico is one of the founder of monoblock. So it's more the question for you than for me. The monoblock now is controversial. I mean, there are different schools. The school of monoblock in which I do one surgery, I solve everything. And then in the monoblock school, there is internal distraction and external distraction. And then there is the B-block school in which the idea is, I do a frontal orbital surgery and then a left for free in the future when is needed. Again, to really answer the question, we should have some outcome, really good outcome values. And this goes back to what I'm saying. It's difficult to answer which technique is better if we don't know what criteria used to judge which technique. In terms of mortality and morbidity, clearly the monoblock has more risk than doing a simple frontal orbital advancement. There is a larger risk of leakage, of CSF leakage. There is a higher risk of problems. Le for free, done several years later after a frontal orbital advancement, doesn't associate the same risk of doing the same surgery at the same time. So we have a lot of CSF leakage when you do a monoblock than you don't have when you do a Le for free in a patient who had a frontal orbital advancement. But on the other part, if you wait 2 years, too many years to do the Le for, you will have all the problems we mentioned before, or airway obstruction. So the monoblock has the advantage that you can do it in an early stage and correct properly the things. So I don't know how to judge, how to objectively what is best for a single patient. We still don't have, I think, all the arguments to say this technique should be done because it's better. And this is the problem with all, as I mentioned, all the craniofacial procedures. In oncology surgery, it's easier. Total removal and non-total removal. Patient is dead, patient is alive. Very simple, basic, a surgeon can understand. The MRI is normal, there is a residue. And we have some other people judging our results. It's not me judging my results. There is the oncologist, there is the radiotherapist, there is radiologist. For craniofacial surgeons, there is no judge. It's only us. The radiologist says, I see that it has been operated on. Okay, that cannot say good or bad. They do for other things. So at the end, it's difficult to also have a randomized trial. We take 20 severe Cruzon, in 20 we do B-block, in the other 20 we do a monoblock, and then we wait in 10 years to know how they're doing. Because as you saw, even in the Cruzon, there is a big heterogeneity, even with the same techniques. So I don't know how to answer scientifically your question.
Federico, Federico. Yes. But What are you doing now for a very young kid with syndromic craniosynostosis and severe respiratory problem?
As I said, it will depend on the degree. If we go back to the face, it will depend on the ossification and it will depend on the laryngomalacia. The last two cases I had, one was a severe appert with very small maxilla malar bone. There was no room to put a pin. There was almost stuck under the skull. So to try to solve this problem from an aesthetical point of view and from the functional point of view for the eyelid, we're going to do a lipofilling of this part to try to promote some bone growth and to cover the lower part of the bulb, ocular bulb, which is not well covered because of the protrusion. But there is no actual room for our maxillofacial to pull it. And the other case that I'm in mind of an upper case, our ENT found a severe laryngomalacia. So we discussed again, is it, as I mentioned, is it really makes sense to try to pull the face if the problem is below? And now the child has a tracheostomy and is developing fine and started to improving. Because the laryngomalacia is also evolutive problem. And once the NT says, oh, is the trachea is strong enough, we will go for a LFO. Because of course we had to do the frontal orbital advancement. We cannot wait to do the frontal orbital advancement. So the factor will be a B block.
Francisco from Argentina, would you say something?
Hello, Francisco.
Yes. Hola, Fede. ¿Cómo va? Fede, I have two questions. The first one is post-shunt craniosynostosis. If you agree, we have to change first the valve, the shunt, no? But sometimes we don't know if you have to perform before the cranial wall decompression. That if you have one idea, the step-by-step in this case. And the other one, if you have a Chiari malformation in craniosynostosis with searings, you perform posterior fossa decompression or cranial wall decompression?
Okay, so 3 quick questions. Thank you, Francisco.
You're welcome.
Let's start from the slit ventricle. So from the slit ventricle depends on which type of shunt you place at the beginning. So in most of the cases, it's a kind of shunt who drain a lot. So if you have a programmable valve, of course, you can try to change the value of the drainage, and changing the setting, you can try to solve the problem. And in some cases, it can be sufficient to solve the clinical point of the clinical aspect of the slit ventricle syndrome, not improving very much the radiology, but it will allow to improve. If you have a fixed shunt, this is, I think, what is the question was about. You're not able. You have to change it, of course, but change it is a little simpler than doing the big scar and the vault remodeling. So the strategy is first you try to change the shunt because it's a simpler operation with a local surgery to change your shunt system. If it does not improve, then you go for the more complex surgery. It's not complex in terms of surgery by itself, but it's complex because of the scar you need to do and for the repercussion it has on the psychology of the parents and child. Because they are not afraid if you tell them, I need to change the valve. If you tell them I need to enlarge the skull, they panic, which is comprehensible. For the Chiari and
sorry, Fede, but yeah. The problem was I performed that 2 months ago. Mm-hmm. I changed the shunt, and I have to go 2 or 3 days after to perform cranial wall decompression because the patient developed hydrocephalus Very important, and we have to perform. Sometimes we don't know if there is something before to know to decide if this patient we have to perform before the craniovolt decompression, or we have to always think in change the valve, the shunt.
No, the idea is that what you want is really to allow the child to have again some ventricles that are able to enlarge. The problem of the slit ventricle technically is that the ventricle have no room to enlarge. So if your child, what happened to your child? You change the valve, you increase the pressure on the ventricle enlarge. So technically, it was not purely a slit ventricle system because his ventricles were capable of enlarging. No?
Sorry?
In your case, the ventricles are enlarged. So which means
very slit ventricles, very slit ventricles side.
At the beginning. But then you drain, you change the drain and the ventricles enlarge.
Because the patient started with headache, only headache without papilla edema, but they have a craniosynostosis per shunt. So we decide to change the shunt.
Yes. And
after that, they develop hypertension. Yes.
With enlargement of the shunt. So in that case, what was the complaint at the beginning?
Sorry?
What was the complaint at the beginning? Why you changed the shunt? Why you changed the shunt?
The first post-hemorrhagic hydrocephalus in neonatology.
You put the shunt, but you mentioned that after you change the shunt, the patient complained of raised ICP.
Yes.
But why you decided to change the shunt? Because he had a radiological slit or a complaint? Clinical complaint?
Clinical complaint.
Yes, related to hyper or hypodrainage?
In my opinion, hypodrainage. Hyperdrainage.
Hyper.
No, hyper.
Hyper. So what you're mentioning is that you went from hyperdrainage to hypodrainage.
In my opinion, hyperdrainage, because the patient had only a catheter without shunt put in neonatologist's time.
Okay.
And right now the patient had 3 years old.
Mm-hmm. Yes. So this is something that goes in the definition of the hyperdrainage at the beginning, and then the question was, is it able to enlarge sufficiently enough not to have the raised ICP but have normal standard ventricles? At that point, the question is what was the setting or the valve you decided to put?
Yes.
If it was too high, it will enlarge, or even if it was too low and it enlarged anyway. Even low, it enlarged anyway. It's the compensation from the brain which is insufficient, and that is normal to do the skull surgery.
Okay.
So it's the normal procedure you're doing.
Okay. And the hour for hearing malformation?
This is something, just to stress that this is something you have to prepare because of the family. The first step is to try to see if you change in the valve, you can solve the problem. But if it's not, you will go for a more complex surgery on the vault. For the Chiari and the syrinx. So the question for me is depending on the age of the child. If the child is very young, I'm trying to do a distraction of the posterior part because I think that there is the possibility to counteract the growth, and it's not in an adult type of posterior fossa and Chiari problem. If it's older, I try to do the compression, hoping that the problem of the gradient is something that is chronic enough to avoid it will aggravate. But it's just a gut feeling. I have no figures to justify my opinion. Sometimes I need to do both. Do the vault decompression and then the Chiari. Sometimes, as I show, I do both at the same time. Sometimes you do the distraction, and with your incision, you go down enough to open also a little bit of foramen. So all these things are possible. Which is best is difficult to say. So in to answer to the question, it will depend on the age and depend on the symptomatology the child has. If the child has any symptoms related to a craniocerebral disproportion, the distraction has all its justification. If the problem are purely related to the chiari, maybe just the decompression.
Gracias, Fede.
Federico, we have two questions. One is, in your opinion, is there a limit age to decide to operate or not a craniosynostosis? And the second question is, what is, in your opinion, the Elio Arnold? Could you explain again the criteria about helmet? When exactly you indicate helmet for the patients?
Okay, so helmet. Helmet is a controversial issue. The helmet can be used for mostly for positional. I mean, I mentioned the helmet not because I use helmet in craniosynostosis, just to be clear. I mentioned helmet because they've been used by some, I think, if I remember correctly, Australian team before the surgery to enlarge a little bit the scaphocephalic heads before doing the decompression. So they tried the helmet in the craniosynostotic population, and they saw that it improved in terms of cranial index. So in craniosynostosis, helmet has no real sense. We want to enlarge, we want to free the brain to allow the skull to grow, not to restrain or to counteract. So the fact that the helmet works has been proven. Also, if the synostosis is there, so you can use it after you did the surgery for the synostosis. Why not? It will be something more to give to the children. It can help you to correct insufficient results. So, for example, a scaphocephalic child, you do just vault surgery here. The front is very prominent. You put an helmet, you know you will improve the shape. But it has no functional effect. There is nothing else. So the use of helmet in synostosis is very limited, depending on some techniques. If you have some techniques in which the opening is not so big, the helmet can help you.
There is two more questions or
but
helmets.
Ricardo, you mentioned the question. The first question was?
The first question is, if, in your opinion, is there a limit to indicate surgery for craniosynostosis? The age. The age limit.
The age limit, I mean, I think it's the maximal limit. I mean, older age depends on the function. My limit is related to function. If a child comes age 12 and complains for any reason, I will discuss about surgery. So it's really related to the function.
Okay.
You answered already these two questions from Jose Ascension Arenas Ruiz. Excellent lecture. Did you believe that endoscopic suturectomy plus helmet therapy can be a good standard for unisutural craniosynostosis? And the second question is, did you believe that IQ is good result with suturectomy and helmets, even if you doesn't do the compression like you do in classical technique to operate unisutural craniosynostosis?
So the IQ with helmets has not been studied. So
okay.
We don't know if when I mentioned the study from the Australian team, they put an helmet and measured the cranial index, and they saw that there was an improvement. They did not study how the children were developing. And again, this is the problem with most of the study, which only focus on the aesthetical problem, on the morphology, but not on the function. So Then the discussion about helmets and endoscopic surgery is something that started more than 20 years ago now. The first cases are back to 30 years ago. And for me, it's difficult to have an opinion because I don't understand why we all move to endoscopy for several techniques, but not for this. So there is something that is blocking us to all adopt this technique, but I did not still understand what it is. As I discussed already with some of you, nowadays, all of us will go to the hypophysis with an endoscope from the nose. Nobody will do a sublabial. Nobody will do an open third ventriculostomy with we all go with the endoscope. So we know how to use an endoscope. The endoscope is not a problem. But why for the scaphocephaly or for the metopic, very few people can do plagios or metopic with the endoscope is something that question me. And I don't have the answer yet. So for the scapho, I think that some scapho can really answer to the endoscopic treatment because the problem is purely on the vault. Other scapho, the problem is not from the vault. For plagio, it's very rare that the problem is the suture. The problem is more the skull base. And all these surgery are limited on what they can do at the level of the skull base. So it's very difficult with a straight instrument to go down to the skull base without pushing down the brain a lot. So I think this is what afraid some surgeons to do, like myself. I don't feel comfortable to go to the pterion starting from the fontanelle with a straight endoscope down here without anatomically pushing all the brain under my endoscope. But for the functional results, we're still waiting. We don't have the functional studies to prove, and some of them that have been published, like the one I show you, they're really scary because they show that the results are not so good as for a standard technique.
Thank you.
Okay.
Dr. Elio, maybe some comments?
Yeah. Hi, Federico. Very nice talk. I appreciate very much. Just one short question. When I started neurosurgery, we used to say that 80% of the cases of craniosynostosis were non-syndromic and were free to do surgery. And now with time, this has changed. Do you think the cases became more complex, or we, with time, we do not evaluate adequately the children beforehand? But what's your feeling? Because we see so many, we just showed us so many complex cases, and this is the reality that we used to say today.
I think that there were more the classical surgical aspect. I do my surgery, then the problem is solved, go elsewhere. So an example I have is Sensenbrenner syndrome. So Sensenbrenner syndrome is one of this gliopathy in which you have different problems, and one of them is kidney. And one of the children we had coming to for kidney transplantation had been operated on 9 years ago for a scaphocephaly. So at that time, when you look, it was not me. When you look at the, of course, as we always say, it's my cousin. It's not never myself. When we went to, you read the chart of this child. He came. Okay, he had 6 fingers, and 1 finger had already been cut off by a general surgeon. And then typical scapho. And it was operated very well by the maxillofacial surgeon at that time, very nicely, good results, nothing to say. 2 years of follow-up, he's doing fine, go back, no need to follow. And the problem with the kidney started age 6. If nowadays the same child comes to the clinic, he has 6 fingers, the genetist is called, because it's not normal to have craniosynostosis and 6 fingers. He will do some testing, the mutation will be recognized, and will enter some nephrologist treatment much earlier. Anyhow, he will end up with kidney transplantation because this is the fate of Sensenbrenner syndrome. But it will allow with a better dialysis, better results, and not on a devastated situation. So the problem always existed, but they were not put together. It would have been a child needed a transplantation. Oh, he had already had 2 surgeries, one for the finger, one for the suture, and nobody would have put the link or all of this. So now we know better the syndrome. We know these things are related. The kidney is related to the skull by the mutation.
Federico, we need to finish. I was someone advised me that the technician needs to close the room.
I'm happy that the clinician. I'm happy that the clinician needs to go to sleep because.
Yeah, I'm sure that for you it's too late. And
Yes.
so, Fede, thank you so much for taking the time to be here with us. And if someone had some final remarks, please talk now.
I think you all have my WhatsApp, so if you need, we can chat on WhatsApp.
Okay.
Thank you, Federico. Just to thank Federico for the nice presentation. I could not stay all the time because I have another thing to do, but it was very okay. Thank you very much for your time. And,
thank you.
Thank you.
Thank you.
Muchas gracias, Fede.
Bye-bye.
Gracias.
Gracias, Federico.
Bye.
Obrigado.
Bye-bye.
Gracias a todos.
Bye-bye.
De nada.
Congrats.
¿Qué pasa con ese pelo? Se está cayendo. No tenés más pelo.
Oh,
Foi
bem, né?
Foi ótimo, obrigada. Muito bueno. Muito bom.